over to you.
Excellent. You two are some of my favorite problem solvers among physicians and role models. So I'm really looking forward to the discussion today. And Mariana, just as a aside, I sent you an email with some of the case details. So if I'm talking too quick, hopefully that will be there that you could just copy and paste to the whiteboard. All right. So we can go ahead and is the whiteboard already being shared? Okay, excellent. So we can get started. So I have for you a 55-year-old gentleman with nausea, vomiting, and abdominal pain. So he reports that the symptoms started about 2 weeks ago, sort of crampy abdominal pain, some nausea and vomiting, fatigue, and some increased thirst. And the abdominal pain often worsened after eating, regardless of what he ate. And it led to some anorexia and just reduced oral intake. However, there are also times he got the pain and he didn't eat. And he's also had some dysuria, some left testicular pain, and maybe his urine output has gone down during this time, he noted, but he did not any chest pain, fevers, chills, night sweats, hematuria, or diarrhea, or really any other symptoms at all. And I think this is a good place to end the first output.
Great. I'll start sharing some thoughts generally on the nausea, vomiting, and abdominal pain, and then maybe Ann Marie tag you in to think about these additional history factors of the testicular discomfort and the dysuria. But starting off the bat, we're beginning to hear a case about a middle-aged man with this subacute syndrome of nausea, vomiting, and abdominal pain. I think immediately factoring all of those symptoms together, our minds do go to the GI tract and many different pathologies that can happen, particularly in the upper GI system over that time course, from gastric problems, including kind of obstruction, pancreatitis, hepatobiliary issues. Really, things are quite wide open here. But I do want to take a minute and think about outside the GI tract, what other syndromes we should just start thinking about early. And that includes generally systemic conditions that make people just feel blah, including GI symptoms. So even chronic infections, new malignancies, really just making it difficult for someone to sort of feel good and have nausea and vomiting, either as a non-specific side effect or as a signature of another organ system that's involved, for example, with increased intracranial pressure, if there's pathology also kind of inside the brain. I think the final kind of comment to add off the bat with the abdominal pain being postprandial is, again, I think a lot of syndromes fit well for thinking about upper GI pathology that's triggered after eating, but we'll have to sort of keep in mind just pure compressive syndromes and making it difficult for this person to take food, with the stomach potentially being completely normal, but a huge spleen or a huge set of lymph nodes actually outside of the GI tract being the main reason why it's difficult for this gentleman to eat and drink. So I think things are wide open here for this subacute syndrome, but we've got a potential set of upper GI and hepatobiliary etiologies to think about, but need to sort of think about what systemic problems could be going on to cause this syndrome, and particularly that postprandial discomfort in the abdomen, thinking about what outside the lumen of the GI tract could actually be causing more discomfort after eating. But tying in the testicular and dysuria, I'd love to hear what you think, Ann Marie.
Yes, thank you so much. And thanks so much for that great summary. So when someone says that they have like testicular pain, I always like to think about like what dermatomes are involved. So we think about the sacral dermatomes, S2 and S3, but also think about, is this primarily located in the GU tract, or is this referred pain from somewhere else, especially with the concurrent abdominal pain? So I'm going to try to be figuring out, is this referred from like a retroperitoneal origin or appendicitis or somewhere else in the abdomen, or is this primarily located in the GU tract? And if it is in the GU tract, is it more the external genitalia or the internal genitalia? So first thing I'm going to want to do is I'm going to want to take a look at the site. That's so important because you definitely don't want to miss something like Fournier's gangrene, especially if there's a history of diabetes or immunocompromise or anything like that. So taking a look is really vital. And then I'm going to be thinking about, what's there and what I need to be thinking of. And so thinking about
the scrotal sac, thinking about the testicles, thinking about the blood flow that needs to get to there, thinking about drainage. So are they inflamed? Do they have a hydrocele or something that can't drain? And then thinking about the urinary tract and the prostate, as well as the testicle, or as well as the penis itself. So, do they have a Foley? Do they have altered anatomy? Anything like that. So like within those organs, first of all, I'm going to be thinking about blood flow. So could there be testicular torsion? This is a no-miss diagnosis. Then I'm going to be thinking about hydrocele and epididymitis. And so here it can be really helpful to elevate the scrotum, see if the pain resolves, look and if it's bilateral or unilateral. And then I'm going to be thinking about things like edema. So is there increased scrotal edema? Very commonly I see in the hospital, people have increased pain and you look and their volume overloaded elsewhere. And then they also have volume overload in their scrotum, which can be very painful and cause discomfort. Do I see signs of an abscess there? And then thinking about kind of other, less common causes like a vasculitis. And then when I layer in the dysuria, thinking about a urinary tract infection, a prostatitis, and then also, thinking about some of the less common fungal etiologies or other things that could cause an abscess or other complicated urinary tract infection. Anything to add to that?
No, I think that was great. And it's just making me reflect, I think, a common real life theme to explicitly share with the group with both of ours is I think the value of these clinical problem solving exercises where we actually think and pause is actually in real life being able to be more hypothesis driven on what you do next. So I think with the symptoms, right, if we were in the emergency room seeing this patient, abdominal pain, nausea, vomiting, we'll do a good GI exam. The testicular discomfort, will do probably a better GU exam than we might in all comers, but just some of the other pathologies you mentioned in terms of things that can be referred into the testicle, being more aware of hip symptoms, back symptoms. As I mentioned, worrying more about splenomegaly and exam. I think the real life value of these academic exercises is really being hypothesis driven with all aspects, including additional history and exam taking. So I think you've just brought up a ton of things that I hadn't even thought of that we should factor into as we get more story and exam from this patient. But we'll hear more, Alec.
Awesome start. So I have a little bit more history, and then I'll give you the fill out the rest of the past medical history and whatnot. So he tells me that he's had a longstanding history of diabetes and says that he's only been intermittently adherent to his medications, unfortunately, due to some funding difficulties, but started his meds again about 1 month ago. But despite this, says his blood sugars have been in the 400s at home. And he also notes 3 weeks of blurry vision, right eye pain, headache, and 25 pounds of unintentional weight loss over the last 3 months or so. And he says he's had 3 prior episodes of eye pain, and the vision seems to go poor when that happens as well. It's been in both eyes simultaneously and separately. And they just kind of last for a few weeks and then just gets better. And this has been ongoing off and on for the last 3 years. And he says he went to the doctor, got some eye drops, didn't know much more information, but didn't really remember if it was helpful or not. So filling out some of the additional history, he has a history of diabetes and type 2 diabetes, and has had an appendectomy in the past, really no pertinent family history. In regards to his medications, he takes NPH insulin, he's on metformin, and he started glipizide about 5 days prior to presentation. He hasn't used any over-the-counter medications or supplements. In regards to his social history, no tobacco use, drinks a few drinks a week, no drug use. He's originally from Guatemala, but has been living in the Houston area for about 20 years. He works as a painter. His last travel abroad was to Guatemala about 8 months prior to his presentation. And yeah, I think that's where I'll stop for here.
Okay, thank you so much for this additional information. You've really layered a deep case, but there's so much information. And frankly, I'm trying to put all the information together. So I'm just going to pause and take a moment to try to make a problem representation. And then from there, think about how this could influence my differential. So please, Steph, in the chat, think about your problem representation right now and think about what you would be adding to my statement. So I have a 55-year-old male with a history of type 2 diabetes, which has been poorly controlled in the past, presenting with postprandial abdominal pain, nausea, vomiting, testicular pain, and dysuria, as well as some weight loss and blurry vision. His relevant social history includes travel 8 months ago to Guatemala. I was trying to summarize on the fly. So Steph, did you have anything that you would add that you would think would be important for solving this case?
No, love it. I think just in the background, we've got this weight loss too. I couldn't remember. So that is, I think, just an important kind of chronic change that's happened amongst these specific systemic symptoms.
Okay. Thank you so much. So here, I think that helps to solve the case. And I think I'm still struggling to know what the center of gravity is. So I'm trying to figure out if the center of gravity is in the abdomen, or if it is in the blood vessel. Whenever someone says that they have eye symptoms as well as testicular pain and some decreased urine output, I start thinking about, could there be some sort of vasculitis or some sort of infection there? Or if it's a more systemic infection with some of the weight loss, or if some of these changes are due to diabetes, and how diabetes is affecting this presentation. So I'm thinking about how diabetes can lead to diabetic ketoacidosis. I'm thinking about how diabetes can affect the kidneys and can cause long-term kidney damage, nephrotic range proteinuria, and can also affect the eyes. So it can cause increased retinal damage and decreased vision. So I'm thinking about that, but also that if you have increased blood sugars, that can predispose to certain infections. We talked about Fournier's gangrene. You can also think about yeast infections, increased incidence of urinary tract infection, more systemic infections. If, with some of this, might be thinking about, like, could there be mucormycosis? That's a common one. Usually it presents with decreased extraocular movements, proptosis, which I'm not seeing signs of. And then if we layer on the history of travel to Guatemala, it doesn't take away any of the common things that I do think we have to be thinking about. Also, because it's a problem-solving exercise. Other exposures like tuberculosis. So especially with the weight loss, and could that be in the background? It can cause a sterile pyuria. So I'd be very much thinking about, could that be at play? And then other fungal pathogens, including the common ones like histo, which is endemic, but also in some parts, more South America than Central America, you have to think about paracoccidioides. So I would just be kind of layering in those factors. Any kind of other thoughts about the medications or other health-related behaviors here?
I think I was thinking a lot about the diabetes also, and just both what risks that puts him in, both for complications of longstanding hyperglycemia as well as infections. I'll just briefly say generally, I mean, Alec and I work at the same hospital. It's Houston's County Hospital. And I do think in this case, it's also just one marker of lack of access to care, and recognizing that something chronic inflammatory has actually been going on for a while with this guy, based on the history of the weight loss and the headaches and the blurry vision. And, for whatever reasons in life, he hasn't been able to get in. And I just say, to me, the diabetes is part of that picture also. Someone who's had sugars of 400s for a long time, it's just a marker of sort of the barriers to care, and potentially why whatever diagnosis we're going to find out this guy has been going on and progressing for a while. It sounds like he hasn't been sick. Yeah, I think it's really hard to figure out where to latch onto with so much going on. I wonder if there'll be a thread to pull with the eye pain, though. To clarify, Alex, it's the right eye. It is painful, but we don't know yet if it's kind of been red to him.
Oh, that's correct.
Yeah. So I think, Ann Marie, you just brought up a beautiful list of both inflammatory as well as infectious pathologies that could be ongoing. And, you know, to me, some of the abdominal symptoms are nonspecific, but I feel like wondering about some of the GU symptoms, as well as how this eye ties in, particularly if we see on exam that that it's red. Thinking about kind of what scleral or uveal pathology overlays with that great inflammatory, both autoimmune as well as infectious differential diagnosis that you came up with. But there's just so much to figure out here. So I do think the very exam focus that we'll get from the physical assessment of him, as well as the labs, might help us figure out where to go. Because at this time, I've got a huge problem list for him, and I'm not exactly sure which one to put as problem number one yet for him in order to actually make a little progress on this. Just being completely transparent about the thoughts. So Alec, why don't you give us some more?
Okay, will do. The fire alarm just started going off, so I apologize for the noise in the background. I'm going to go on to the physical exam next. So the patient was afebrile, heart rate was 90, blood pressure 160/90, saturating 99% on room air. His BMI for context is 16. So in general, no acute distress. He does look cachectic. On HE&T, I'll just get to the eye exam. So he had some right-sided scleral erythema and injection, but no appreciable discharge, swelling, exophthalmos. He did have some photophobia, though. The pupils were equally round and reactive to light, however. The left eye was totally fine. The extraocular movements were intact and symmetric. And one of my medical students had a Snellen chart, so we used that. And the vision on the right was roughly 2200, and on the left was 2040. But color differentiation was fine, and the visual fields, the best that I could do, were intact. And there wasn't any jaundice or anything. And he had some poor dentition. In regards to the rest of his exam, nothing pertinent on the cardiopulmonary exam. GI-wise, he was soft, non-tender. There was no focal tenderness to palpation. In regards to the GU exam, he had some mild left testicular swelling and tenderness to palpation, but no erythema or warmth. He didn't have any penile lesions or discharge, and there was no appreciable inguinal lymphadenopathy on my examination. He had no rashes, he had no edema, and his neurologic exam otherwise was completely normal. And that's the end of this outline.
Thanks, Alec. Actually, really helpful. And I think the 4 things that stand out to me from the exam are the cachexia, his hypertension, which for a guy with a BMI less than 18 is standing out to me as something notable to talk about. The inflamed red eye, as well as the overt testicular findings there. I think to provide some brief comments on each of those, the cachexia speaks to the unintentional weight loss and what we're calling right now likely kind of chronic inflammation. This gentleman might have access to food resources as an additional factor, but to have a BMI of 16 with all of these chronic symptoms is very, very concerning for a lot of those chronic inflammatory conditions that you mentioned, Ann Marie. The hypertension is surprising in the setting of that. You know, hypertension can happen in, right, people with normal BMIs very commonly, right? We see it in the setting of metabolic syndrome and obesity. So in this case, I would actually go back to the history and ask him if he's been ever told before that he has essential hypertension. And if not, really kind of worry about what's driving that. Particularly really start worrying about, is the kidney actually part of an organ system that's inflamed during this what seems to really now be systemic condition also. The scleritis, similarly, I think, as you mentioned, Ann Marie, really brings up the question of some of those chronic inflammatory conditions, tuberculosis and histo really being in the infectious category, as well as a whole host of autoimmune categories, including vasculitides is going to be a very important thing. And I think having a formal assessment from ophthalmology to really help us identify layer. Is it sclera? Is it uvea? I'll say on exam, I think it's very difficult for me to tell without some of the additional tools, and slit lamp will be very helpful. And then the testicular swelling also, the kind of 3 pathologies that I would worry about are, in a middle-aged man, still the risk of testicular malignancy, although I would more commonly think of a painless swelling there. But certain autoimmune syndromes can affect the testicles, particularly vasculitides like PAN, do have a predilection for the vascularity of the testes. And then infections too, TB, histo, all of that can actually go also to visceral organs, including the GU. So I think kind of testicular ultrasound will be very helpful to see if we're dealing with any solid lesions versus just enhanced blood flow and tenderness from increased perfusion. Will help us kind of put together these now inflamed findings of both the eye and the testicles, with again an eye on, no pun intended, some of those chronic infections as well as autoimmune conditions. Anything to add to that, Ann Marie, on the exam stuff?
So I think that was a really good summary, and I think we still have a lot of questions here, but we can start forming hypothesis and form our Venn diagrams and see what's overlapping. And in my mind, a lot of this is kind of the diabetes and saying, how does this overlap with the vasculature, and saying, is there some overlap thinking about a vasculitis or some sort of systemic infectious etiology affecting it, and really being like curious and doing kind of with the lab work, helping that guide us, but also having some like hypothesis driven lab tests, such as sending the hepatitis, thinking about evaluating for tuberculosis as well, seeing what the creatinine shows, sending a urinalysis. So I'm excited to get more info here.
Okay, amazing discussion. So I'm going to get some labs and imaging to start. So in regards to the CBC, the white count was 9.2, neutrophil predominant. Hemoglobin was 9.5, and the platelets were 346. In regards to the BMP, the sodium was 118. The potassium was 5.6, chloride was 84, the carbon dioxide was 19, the BUN was 118, the creatinine was 6.2, and about 4 years ago, it was 0.5. We don't have any data in between then. The glucose was 530. The calcium was normal at 8.6. Magnesium and phos were fine. And in regards to the liver chemistry test, most notable for a total protein of 9.6 and an albumin of 3.3. Otherwise, they were normal. And lactic acid was fine. Beta hydroxybutyrate was normal. The lipase was normal. The hemoglobin A1C for context was 13.4%. I have a urinalysis, which showed for Uncle Bob a specific gravity of 1.010, and no ketones, 2 plus glucose, no nitrites, but 2 plus leukocytes, 2 plus blood, 7 RBCs, and 52 whites, and just said few bacteria. There was a urine protein to creatinine ratio of 1. EKG was normal sinus rhythm. And then in regards to imaging, had a renal ultrasound. The kidneys were normal size, slightly increased echogenicity, no hydronephrosis or obstruction, but the bladder was distended, estimated volume of about 500 cc's with quote unquote echogenic debris. Chest x-ray was fine. There was also a CT and abdomen and pelvis done without contrast, which again showed a distended bladder, some prostomegaly, and some age-related degenerative changes of the spine and SI joints, but no colonic or small bowel pathology, no biliary dilatation or gallbladder pathology, and no hepatosplenomegaly. Couldn't really assess the vasculature without the contrast. And there was a scrotal ultrasound done, which showed left epididymal orchitis, but no evidence of torsion.
Awesome. This is really great information. If it's okay, since there is a lot of information here, I'm going to summarize the labs, and then Steph, would you summarize the imaging findings, and then maybe do a recap to see where we are at the end? So here we see a WBC count of 9.2. I'm not surprised by that because I expect it to be more chronicity in this. One thing I would be looking at is the differential to see is there lymphopenia, which, you know, it will be very important to know his immune status. We know he's immunocompromised from his diabetes, but thinking about HIV and etiologies like that. And then I'd also be looking at the eosinophils to see if there's eosinophilia, because that would clue me into funky inflammation here. And then, you know, the platelets just reflect probably some chronic inflammation there, but there could be concurrent iron deficiency with that decreased hemoglobin level. And then I think a lot of it in the chemistry, you see some pretty, you know, significant findings. Just a reminder, whenever you have hyponatremia, you want to correct it for the hyperglycemia. So it's always hard to do math live, but it looks like it partially corrects, but does not fully correct. If you did 4 times about like 1.6, so you'd be about like 7. So get to like the mid 120s corrected. Some people say up to 2.5, but here, whenever you see the combination of a low sodium and a high potassium, I'm thinking about a few different things. The first thing I think about is adrenal insufficiency. Here, I think that's less likely with the high blood pressure, but still something I'm going to be thinking about, especially since certain granulomatous diseases can affect the adrenal glands, such as TB. And then, you know, that's part of the reason why I was thinking about the EOs too. And then you have to think about, are the kidneys working correctly? And here we see a very elevated creatinine. And then on the specific gravity, we don't have an osms, but the Uncle Bob trick is to multiply the last 2 of the specific gravity by 30 to get approximate urine osm. So it looks like we have isostonuria, which means that the serum and the urine are about the same osms, which makes me think that the kidneys are not appropriately concentrating the urine, which could speak to a problem in the loop of Henle. And also sometimes we can see it as chronic kidney disease progresses. You first lose the ability to concentrate the urine, and then you stop making as much urine here. The other things I think about with the combination of low sodium and high potassium are just like some of the sorry, I'm losing my train of thought, but those are kind of the 2 that like I kind of initially think about and would want more information on. And then here, just a note, the creatinine is 6.2. I'm not very surprised by this because I was anticipating that the creatinine might be elevated with some of the decreased urine output. So here it's going to be really important, you know, when we think about an elevated creatinine, we're thinking about pre-renal, which certainly could be at play here with having poorly controlled diabetes. Maybe he's just having increased urine output. So we're definitely going to want to carefully rehydrate to see where the creatinine ends up. But based on the urinalysis, I don't think that's the only thing at play, because with that, you should not have this effects on the urinalysis. So I'm really thinking about a possible intrarenal process. And with intrarenal process, you think about the glomeruli, which the glomeruli are important gatekeepers in keeping protein out of the urine, and then also keeping other stuff out. So the fact that there is protein in the urine, as well as red blood cells in the urine, makes me wonder about this. It will be really important to look at the urine under the microscope to see, because usually the RBCs of glomerular disease, you can get acanthocytes, the little Mickey Mouse ears on the RBCs, although the lack of them does not exclude a glomerular process. And so it will be really important to look at it under the microscope. Additionally, the white blood cells being present, sometimes you can see it if you have a lot of blood, but I'm also wondering about a sterile pyuria process or an acute interstitial nephritis. With an acute interstitial nephritis, he doesn't have any of the known drug exposures, but you can sometimes see increased WBCs in WBC clumps. And then I'd also want to know if the urine grows, because this could be a urinary tract infection as well that can sometimes predispose to hematuria. And so I'm definitely going to be, thinking about evaluating for the vasculitides here, specifically nephritic syndrome rather than nephrotic syndrome. Is there some proteinuria, but it's less than 3.5? There's also RBCs present, as well as hypertension. And so those are going to be kind of some of the hypothesis I have going into next step. It is important to think about that multiple etiologies can be present at once. And so I am still wondering if there is a post-obstructive process. There is no hydronephrosis, but it does look like the bladder was distended and there was some prostate enlargement. So here I'd put in a Foley, decompress, give fluids while working up an intrarenal process as well. And then thinking about the overlap, they could be unrelated processes, but what could affect the kidneys as well as the eyes, and thinking about your infectious things. So tuberculosis, certain viral infections, HIV, CMV, EBV, some of your other chronic granulomatous diseases, syphilis as well. That's usually a more nephrotic picture. And then thinking about your nephritic bucket, so your vasculitides, so thinking about your hepatitides, checking hepatitis B, hepatitis C, thinking about ANCA vasculitis, thinking about complement-mediated vasculitis, including a infection-related glomerular nephritis that could lead to like an endophthalmitis. So making sure that thinking about checking blood cultures, doing a really good heart exam to assess for murmurs, looking for other signs of endocarditis. Two, thinking about other autoimmune diseases like lupus, rheumatoid arthritis, although I see less here. So I'm excited to hear more. What are you thinking of the imaging findings?
I think to jump off of what you said, particularly about the renal abnormalities, we are getting very worried for an intrinsic, whether interstitial or glomerular process, but 100% agree. We're going to put a Foley catheter in because of that prostatomegaly and bladder distension to really make sure we're both sort of seeing what element obstruction may have, early obstruction, because there's no hydronephrosis, as you mentioned, as we kind of work up the kidneys otherwise. So to me, the renal ultrasound is helpful, just kind of lowering that threshold to make sure that the bladder is drained fully with the catheter. But also the normal kidney size, I think, is worth commenting on. In more chronic kidney diseases, right, over the years, we're used to seeing sclerosis in the smaller kidney sizes. And there are certain renal conditions in which you can get a renomegaly. Actually, diabetic nephropathy is one of them. It can happen in HIV as well. So the fact that they're normal isn't particularly specific or anything, but speaks to something that's at least more subacute as opposed to chronic over the years. The chest x-ray, I think, is most helpful in its negatives. We don't see large hilar lymph nodes that could make us concerned for sarcoid, which could have a multi-organ system imprint on the eye and everywhere else, as we're starting to see. So that's worth noting. There's no parenchymal pathology in the lungs, with the caveat being, chest x-rays are negative for a lot of interstitial processes, but I'm not sure I would go interested in a chest CT right now. It really doesn't have any cardiac or pulmonary symptoms. I think the normal cardiac silhouette, also just worth commenting. You mentioned, Ann Marie, a lot of these conditions do have predilection for the heart, including pericardial disease. It seems right now that there's not a big cardiopulmonary signature based on his lack of symptoms, and the normal x-ray, again, CT ultimately more helpful for that, but doesn't seem to be that that's a major organ system. And I think otherwise, the scrotal ultrasound, it tells us that both the testicle and the epididymis are inflamed. Completely agree that this gentleman with an A1C of 13 could have run-of-the-mill, right, GU infections, and so getting a urine culture for common gram-negative rods, screening for gonorrhea and chlamydia, very, very important causes just in general of epididymitis. But again, the question will be, does it tie in with his inflammation that we're starting to see everywhere else, which appears to be renal, eye, testicular. We're really getting this multi-organ imprint. So where do we go from now? I completely agree with that robust workup up front for intrinsic renal disease. We'll put the Foley in, we'll give him some fluids to sort of both test and treat pre-renal as well as obstructive etiologies, but 100% need to look at the urine microscopy closer, send complements. And again, layering on some of this potential scleritis, really start getting into some of these specific diagnostics that you've mentioned, Ann Marie, checking an ANA and a C3, C3-4, ESR, CRP, they'll be elevated. I think it'll just help us sort of make sure we're in the right category. RPR for syphilis, tuberculosis, a T-spot might be anergic in the case of this is disseminated TB, but could help us assess general pretest probability coming from Central America. Urine and serum histoplasmosis would be early things to get off the bat. And then sort of taking it from there. HIV screening, of course, would be a pivotal point at this spot. But it sounds like you got more data for us, Alec, and help us make sure we're sort of pacing nicely too.
Yes, for sure. I got a lot of data for you. So just as an update so far, so put the Foley in, 750 cc's of urine came out pretty quickly. Started him on some antibiotics for possible UTI and started some tamsulosin for presumed BPH. We did do a DRE, no prostatic pain or tenderness, just a large, pretty symmetric prostate. And his acidosis, hyperglycemia, hyperkalemia, hyponatremia, all that got better with just insulin and fluids. So for some additional lab testing, HIV was negative, Hep B and C testing was also negative, had a gonorrhea, chlamydia in the urine, PCR, which was negative, had an SPEP, which just showed increased polyclonal gamma globulins. There was no monoclonal spike. And the 24-hour urine showed about 400 milligrams of protein, but the electrophoresis was negative. And both the kappa and lambda free light chains were elevated, but the ratio was normal at 1.7. And his anemia testing was all consistent with anemia of chronic disease. And we have an exam by ophtho, which demonstrated pan-uveitis of the right eye on slit exam, and also posterior synecdoche in the left eye, which was concerning for a prior episode of inflammation, but no papilledema. And I think I'll stop there. And there'll be about 2 more aliquots after this before we reveal the final diagnosis.
Great. Thanks, Alec. So I think very appropriate to treat for common urinary infections. As we said, we can kind of see how it's syndrome. But yeah, with the pan-uveitis and prior episodes, just as we said, we're worried about whatever the smoldering underlying pansystemic condition is. I think commenting on the protein gap, we now know this is from a polyclonal, multiple proteins being produced at the same time, as opposed to having a monoclonal protein elevate that. That remains fairly nonspecific, can be seen in a lot of chronic inflammatory conditions, HIV, lupus, etc. So I think a NA remains a kind of helpful next test for him. But with these additional tests, I think we've ruled out some other etiologies that could have been separate problems, like we said, such as the STI infections, but we're not really a lot closer to what the primary diagnosis is. So in addition to kind of wanting some of the more specific autoantibodies that we mentioned before, as well as the serum testing that is available for some of these, as we said, chronic infections that we're worried about, I'm starting to wonder, and I'd love to tag you in on this, Ann Marie, like, what is our next step? Are we going to need more imaging? Are we really at the point where getting tissue from somewhere is going to be critical, particularly to look for inflammation of the vessels, for example, right? Do we actually need a biopsy of the kind of testicular region or the epididymis? Because some of the things that we've mentioned won't necessarily have a serum signature, something like polyarteritis nodosa, right? We're actually going to rely on kind of tissue and histopathology to make that diagnosis. So curious what you think. I'm struggling to think what more imaging would be helpful. And in addition to some of those more specific diagnostic tests, kind of wondering if we're going to need pathology for this.
Yeah, I completely agree with that. You know, I think we could think about getting a contrasted CT scan since the original one wasn't contrasted after some rehydration, seeing what the kidney function does. Of course, contrast, there's kind of this controversial whether contrast-induced nephropathy exists, but it certainly is some risk, especially, you know, the higher the creatinine is, if they're dehydrated, if they have diabetes, all those are risk factors for this, although kind of how prevalent it is, how commonly occurs. Recent data shows, especially with the newer lower osmolar agents, it's much less common than was originally thought. So I think that we could think about that and see if we saw lymphadenopathy or anything like that. But I agree. I think I would probably start with, I would be talking to infectious disease and rheumatology and say, like, hey, I'm worried about tuberculosis, but I'm also worried about a vasculitis. How can we make progress? Thinking about kind of sending the ANCA levels of the serum, sending kind of the initial, but then I think renal biopsy would potentially be a good place to start, but also thinking about the other involved places. So talking to optho to see if they would think that, you know, there was anything that we could look in the eye. Would sampling be helpful? And then also thinking about the testicle as well. Would sampling, you know, you have to be careful because if you're worried about testicular cancer, you obviously don't. But, you know, is there something in the area that could potentially be sampled? So that would be kind of what I would be doing, but it would definitely be a multidisciplinary approach, talking to all the teams, trying to figure out like how can we make progress here.
What'd you guys do next, Alec?
Amazing thoughts. So I'll give you some more information here. So had a CK, which was normal, TSH was fine. Did do the complements. C3 was normal, but C4 was undetectably low. And did lots of infectious testing for the sake of time. Everything was negative except for the quantiferon, which was indeterminate. And for the autoimmune testing, ANA was negative, and every other antibody that we sent was negative also. We did do some additional imaging at recommendations of some of our consultants, and did do an X-ray of the SI joints, which didn't show any radiographic abnormality, no evidence of sacroiliitis. Did do a CT chest. It was without contrast, though. Showed a calcified left hilar lymph node, suggestive of prior granulomatous disease, but nothing intraparenchymal, no intraparenchymal abnormalities, I should say, and no hilar, mediastinal, or axillary lymphadenopathy. And despite placement of the Foley and some fluids, and a completion of a course of antibiotics, the creatinine plateaued around 4.3 from 6, and his pyuria and mild proteinuria persisted, although his testicular pain and swelling had all resolved. And the initial urine culture ultimately didn't grow anything. And we did spin his urine, didn't show any dysmorphic red cells or red or white cell casts, though a few urine eosinophils were noted for whatever that's worth. And we did repeat the quantiferon, which ended up being negative. And then we'll have one more aliquot, and after that will be the diagnosis.
Okay, lots of rich data here. And so the calcified lymph node could be a lot of different things. It could be a prior history of tuberculosis, it could be histo, it could be kind of other things, but I definitely think we have to keep that in mind as we go forward, saying like, could there be some sort of granulomatous disease that poorly controlled diabetes allowed to disseminate? But there doesn't seem to be another thing of like active inflammation there, and the lack of hilar lymphadenopathy makes things like sarcoid much less likely in this case, and some of the other fungal etiologies commonly involve the lungs as well. So I think that that is helpful data to guide. The low complement levels, you said the C4 was undetectable. Is that right?
That is correct. C3 was normal, C4 was low.
Okay. So normally what I think about like with that is sometimes it can be low in cryoglobulinemia. Normally the C3 is lower in post-strep, HIV, and C3 glomerulopathy. So I definitely be thinking about sending an RF to see if it was elevated. because they say RF is the quicker cryoglobulins, thinking about sending cryoglobulins here, although it doesn't sound like there was palpable purpura or kind of other things here. Sometimes you can just get one complement that's lower than the others. But the ANA, it sounds like, was negative, which basically makes lupus very unlikely. We haven't had like dry eyes or dry mouth that would make me think about Sjogren's syndrome or things like that. Doesn't sound like, at least on blood cultures, that we've seen obvious signs of endocarditis. And it doesn't sound like there's anything on the echo exam. I'm still worried about TB. I think we have to be thinking about here, how reassured do we feel by a negative quant gold? So I'm still worried about TB. I'm still worried about histo and some of the other fungal etiologies here. And so I'd still want to send like a urine histo as well. And I still would, consider doing a renal biopsy to try to better understand. But it sounds like with some of the pyuria and eosinophils, we might be dealing with possibly a component of AIN as well. And so I'm just trying to think about like kind of what infectious things could overlap in cousin AIN. Concurrently, I know sometimes I think about IgG4 disease, but I don't have like pancreatitis or other things that clue me in on that. So still really worried about the infectious category here. Steph, do you have any like good differential for kind of other things that we could be thinking about here that could cause a potential sterile pyuria / AIN picture? Maybe some brucella or Bartonella would be kind of some other things to add to that list. So asking infectious disease and thinking about sending antibody testing for that, considering the history.
I'm so glad you said those two words. I had them in my mind, of this continuous presence of white blood cells in the UA in the absence of an infection is pyuria. Without an infection, sterile pyuria. And it itself has its own differential diagnosis that becomes very critical here. And just as you said, can be seen in interstitial nephritis, whether drug-related or infection-related. Tuberculosis can do it. Leptospirosis, which isn't really a consideration here, but can do it. It can be associated with STIs, which, at least for the common ones, we haven't found here also. It can be associated otherwise with just sort of drug effects. So I think getting more specific on what the kidney pathology is, yeah, it's persistent kind of sterile pyuria, but with this hypocomplementemia also. And I think your thoughts in particular about cryoglobulinetic vasculitis, presumably sort of a mixed one. We didn't pick up a monoclonal protein problem on the SPEP, is an important concern. And then IgG4 related disease, when it involves the kidney, it is hypocomplementemic. I believe it's usually both C3 and C4, but an important consideration all for primary kind of interstitial pathology. So I think we really need the renal biopsy at this point. And then some of those additional kind of serologic tests that you mentioned will help us get a little bit closer for this disease, which is causing this chronic weight loss, uveitis, as well as kind of nephritis picture here also.
Excellent thoughts. So just to be more specific, all the infectious and autoimmune testing that you requested for treponema, Bartonella, brucella, we did toxo, histo, everything was negative. And for the autoimmune testing, cryos, rheumatoid factor, everything that you could possibly think of was negative. So as requested, we did do a renal biopsy, and it showed plasma cell rich interstitial nephritis. And I'll just read you the report. So tubular interstitium shows dense and diffuse involvement of inflammatory infiltrate, consistent with the CD56 negative polyclonal plasma cells. All the staining for IgG4 and spirochetes were negative. And then we had a urine beta-2 microglobulin, which was very, very, very elevated. Normal is less than 300, and his was 2,000. And that's the last outcome.
So I have a few final thoughts. Just to be frank, I'm not sure what it is. I know there is an etiology called TENU syndrome, which is tubular interstitial nephritis and uveitis, which, I feel like if we've excluded everything is a possibility here. What I'm kind of struggling with is how the beta 2 microglobulin fits in with this. With having worsening renal disease, it can sometimes be elevated in kidney failure, like with, like, is this like some sort of amyloid picture, even with the normal light chain? So some other sort of amyloid, it can be elevated in end-stage renal patients who can get like an amyloid like picture related to that, or like with like lymphoma and malignancy. So I'm not sure exactly how that would play in, but I'd love to hear more. Steph, do you know anything more about that?
I heard the TIN and I thought, oh, we've got the U. And so just this kind of, it's a syndrome, right? At the syndrome of having both tubular interstitial nephritis and uveitis is there. With the dense plasma cell infiltrate. And thank you, Alec, for telling us, the conditions to really think of dense plasma cell infiltrates in tissues that come to mind is IgG4 and syphilis, but, appropriate testing was done against that. So at this point, I think with the elevated beta 2 the question is, is there actually a sort of underlying kind of proliferative process that we're not getting a full kind of monoclonal protein on? The kappa lambda light chains were slightly towards the kappa, right? Was that right, Alec?
Yes, but the ratio ended up being wrong.
Yeah. Because there should be reduced clearance of the kappa relative to lambda and renal disease. So this is something where I talk to a hematologist and say, hey, does that ratio make sense for the degree of this gentleman's glomerular dysfunction? Or would we actually expect it to be way more skewed? So my question here is, is there a question of underlying TINU related to actually a light chain mediated process that has kind of been hard to pick up thus far? Any reflections on that, Ann Marie?
I guess I would be curious about if Conga red staining was done, and then also if like they found any like storiform fibrosis, which I can sometimes think of with IgG4 related disease would be kind of like the things I'd be wondering in an IgG4 ratio, but I honestly am not sure here.
Well, excellent thoughts. And Congo red was negative. There was no comment specifically about said fibrosis, but the clinical suspicion for IgG4 disease with everything was felt by the subspecialist to be a little bit lower. So you both nailed it. The final diagnosis was tubular interstitial nephritis and uveitis syndrome, just because everything else was excluded. So in regards to how the patient did, in absence of alternative etiologies, we made his diagnosis. We started him on prednisone, and within 2 weeks, his pyuria had resolved and his creatinine went down to 1.6. He had a very significant recovery there. And his nausea and vomiting and anorexia actually got better just with a bowel regimen, and he was incidentally found to have H. pylori and was treated and improved. So didn't really think the uremia may have been contributing some, but felt that was less likely to be a part of his syndrome. And his ocular symptoms all resolved very quickly after the steroids as well. As far as his long-term follow-up, unfortunately, he was no longer within our system, so I wasn't able to see, but just an amazing discussion, and just learned a lot from you all. And shout out to Ibrahim, who put TINU in the chat at like 11:35. So awesome. What are your reflections?
First of all, thank you so much for presenting an amazing case that really, really stretched us. I think here it's just that sometimes it's hard to find the center of gravity, and I think that that's okay. And sometimes you kind of have to have a problem list, be thinking about it, and be open to the fact that as the case evolves, things might go up or down, or your center of gravity might change, and like just be upfront when you're not sure. And also be upfront when you don't know, because there's a lot of times in this case where I didn't know and I need subspecialist help. Steph, what are your thoughts?
Yeah, I love an intrinsic renal injury case where it was not glomerular, right? In the end, I think just in the end, an important pivot point was thinking about the sterile pyuria in particular and what that meant. So shout out Ann Marie for sort of putting those words together and helping kind of put that framing there. But I'll just say it was a ton of fun. Really appreciate the time you put into prepping it, Alec. And Ann Marie, always so fun to bounce off you and hear your thoughts. So really value everyone's time. And Gia, if you want to take us home with some teaching points.
Okay, sure. So today we get a very amazing and interesting case. We had a 55-year-old male with a history of type 2 diabetes, presented with a lot of symptoms: nausea, vomiting, abdominal pain, left testicular pain, decreased urine output, uveitis, and weight loss. And initially, we had a discuss of these GI symptoms. First, we need to consider the GI pathology, like from the stomach, pancreas, or hepatobiliary system. And also, we need to consider things out of GI, like some systemic condition, infection, malignancy, or any side effect of medications. And also, the patients have some symptoms of the GU tract, and we need to think if is this in the external or internal GU systems. We need to think about different organs in the GU tract, and also need to think some less common conditions like vasculitis. And because patients has so much symptoms, so we kind of think about which is a key point is the center of these symptoms, and there's so many symptoms actually make us to think about the chronic inflammatory conditions in this patient, and his physical examination further proved this point, and we considered his diabetic condition because it could increase his vulnerability to some opportunistic infection, and the DKI, kidney dysfunction, and retinal damage could also contribute by diabetic. And we also think about other things out of his baseline condition, like the systemic infection or autoimmune disease. And furthermore, we get some labs of for these patients. For the WBC, we discussed we should look at the lymphocytes, eosinocyte, and for the hyponatremia, first because the patient has diabetic, so we need to consider to correct it with glucose number, and also need to considering the urine analysis of osmolarity to analyze the etiology of hyponatremia. And these patients' urine analysis actually concerns us a lot of the intrinsic renal process. And then we discuss the importance to see the RBC in microscopy to see whether it's nephrotic or nephritic. And we discuss several possible etiology for the intrinsic renal process, like HIV, EBV, or any hepatitis virus infection or autoimmune disease. And furthermore, we discuss the further investigation we should do, like imaging versus renal biopsy. The patient's CT scan revealed calcified left area, which we should further work on like TB, fungal infection, and granulomatous disease. And then the patient's renal biopsy revealed plasma cell infiltrate, and finally lead us to diagnosis that actually it's my first time to hear this name, the TINU, and that's all I learned from today's case. It's very amazing. Thank you all for this discussion.
Thanks, Gia. That was awesome. And thanks everyone else for joining. We really appreciate your time, and shout out to Alec on the consult service for taking an hour early out of rounds to help us out. Really appreciate it. Have a great day, everyone. So I saw your teaching point, Alex. So it's a tubularly
Basically, like when there's tubular damage, it's no longer reabsorbed, so the urinary level is higher. It's not specific, but it has a good like positive and negative predictive value from what I was reading. You know, there's only about 500 or so described cases, more common in pediatrics, but it was really interesting. I never heard of this, and just as like part of their typical differential, you know how Opto puts all their stuff in their notes about
Yeah.
the uveitis. For them, like I don't know, third day they saw him, they just threw that at the bottom, because I think our initial running concern was that this was probably just related to an underlying urinary tract infection, you know, particularly with his obstruction and everything, and it was just the persistence and then his lack of improvement in renal function. And you know, striking for someone that had diabetes for so long to not have significant proteinuria, like you had said, his kidneys were, you know, roughly normal sized. He didn't have significant neuropathy. His eye exam, he didn't have significant diabetic eye disease either. So I think it really sort of tipped us off. There was something else going on, and yeah, it was just a really, really good case overall. You guys did an awesome job. That was super fun. You're ready.
It was it was a good practice case. I saw one case years ago, and it was in a young woman. Do you need a biopsy to make this, or could this kind of, once the eye was out there and you saw it was non-glomerular, you still need a biopsy?
Yeah, that's a good question. From the literature I was looking at, it seems like if you've done a good job excluding everything else and renal biopsy for whatever reason was felt to be too high risk, that in theory you could make it. But I think there was still a significant amount of diagnostic uncertainty with his underlying comorbidities that they felt it was useful to rule out other things.
Yeah. And so in retrospect, the kind of abdominal symptoms were non-specific, maybe urinary retention, maybe GU infection, maybe diabetes. I mean, well, I guess that's interesting though. He didn't have a lot of other diabetic neurologic symptoms, so it wasn't gastroparesis, but that all got better pretty quickly.
Yeah, and you know, that was my initial concern, but then he didn't have any of the renal manifestations. We ended up doing a gastric emptying study anyways. It was completely normal. And I just, you know, as his clinical course went on, it just went further away from infectious / diabetic related. And luckily we were able to make that diagnosis. But I learned a lot in that case. I honestly thought that he had ocular TB and sort of interstitial nephritis. So I was talking to Opto about, you know, getting a sample from his eye, especially when the quantiferon was like, I didn't know what to do with that. But
and did you guys get an MTB PCR urine too as part of the eval?
We did not, actually. That's a great point. But that wasn't something that we ended up getting. And can't remember if we talked to ID or not. But then in the end, it felt like it was less likely that he had TB. So he just had a very dramatic response to steroids, which I guess everyone felt overall that the diagnosis was fairly consistent. Even the pathologist for that read the renal biopsy thought it was potentially consistent.
So cool. Thank you. Awesome case. Great teaching. Hey, Hans. Hey, Mariana. Thanks for coming. Kimane is asking, how did you guys feel totally confident it wasn't TB?
I think he didn't have any other clear manifestations, although TB can do anything. And then we did do a repeat quantiferon, which was negative, although again, in active disease, it's hard to know. And then I think we found he had been tested for TB previously and had been negative and hadn't really had any known exposure. So could we say that with 100% confidence? No. But the fact that he clinically improved for this long without treatment and didn't have worsening of his tuberculosis seemed to be potentially less consistent. I guess we were now just using time as our diagnostic test, but I guess it's 100%. We cannot be 100% confident that he didn't, but his clinical syndrome seemed more consistent with TINU.
Very cool. Opto helped. I was on service last week and they helped us with a lot, pushed to the right diagnostic category in a lot of patients. So yeah, so cool. Thanks again, guys. Thanks, Alec.
Thanks, everyone. Have a great day.
Have a great day. Bye.